the bulk of my discussion is really what they want. You will be surprised how different patients are in terms of what's important for them. One side of the spectrum, I have patients who really don't want a treatment that's forever. And that makes sense, right? No matter how safe the drug is, no matter how disease-free you are, just for some patients, just the thought of being on a medication forever that's for cancer is important, and they just don't want it. They want to be disease-free, but also treatment-free as long as possible. And so that's important for some patients. And in the appropriate setting, if I feel that yes, we can go with either chemotherapy-based therapy in this patient, or now venetoclax-based therapy is a non-chemotherapy and a time-limited option potentially, right? So for those patients, based on that decision, of course, that's what I will provide to them. I also have patients who really don't, I'm taking 4 medications for years for different drugs, and you give me something, I don't want to deal with the whole ramp up and checking MRD. As long as I'm fine, I'll take it. So that you see both sides, and you do see patients who still come for chemotherapy. So yes, patient preference is important. Patients need to understand and need to be educated on what to expect. It's always easy to start treatment. We get patients who come back 6 months, 7 months later, and you know what? I'm taking this for 7 months, it works, but can I stop? I mean, what do you mean it's going to go forever? The doctor who started didn't talk to me about it. So I think those conversations are actually very important. And I add one more thing. They're important because we don't have a head-to-head trial that tells me that acalabrutinib or venetoclax, which one is better. If I have that, then I probably won't give that option. Or if I do, I make sure they understand that they're going for a treatment that's not superior, but we don't have that. So really, you have to sit and present both treatments and pros and cons and have them decide based on what's the best fit for them. And that's why it's important to have really a comprehensive and kind of an approach to the patient, and not just focus on, it's really treating a patient, not the molecular kind of finding in the CLL cell. And that's a common mistake. Oh, I have somebody with a mutated, let's give chemo. No, you have a patient who has CLL, whose CLL has this. So then you kind of look at the patient and not the other factors.